This video is made for OT practitioners to provide info regarding the therapy and protocol process for flexor tendon repairs. We will begin by going over the flexor zones of the hand. The Zone 1 area is distal to the flexor digitorum superficialis insertion on the midpoint of the middle phalanx. The Zone 2 area goes from the A1 pulley to the flexor digitorum superficialis insertion. Zone 3 region is from the distal end of the carpal tunnel to the A1 pulley. The Zone 4 region consists of the area within the carpal tunnel. The Zone 5 area is the proximal aspect of the transverse carpal ligament to the musculotendinosus function. For flexor tendon zones of the thumb, the Zone T1 region is distal to the thumb IP joint. The Zone T2 area is from the A1 pulley to the IP joint. The Zone T3 area consists of the thenar eminence, and it may be helpful to keep a picture of all flexor zones handy when going over post-op protocols. The healing process for flexor tendon repairs takes at least 6 months. Tendon healing is both an intrinsic and extrinsic process. When intrinsic healing dominates the process, it results in less tendon adhesions and freer tendon gliding. Repetitive use must be avoided as it increases the risk of rupture, which may ultimately slow down the rehabilitation timeline. When extrinsic healing dominates the process, there are more adhesions that frequently present as a result of increased inflammatory response. This response may occur because of infection, multi-system injury, a high-energy injury, or other factors. Tendon gliding will be much more restricted in this case as a result of adhesions. The pace of the rehab timeline should be increased in order to break up the forming adhesions. Overall, all timelines rely on the patient and may not be followed exactly. On this slide is the pyramid of force model created by Groth. This model has created the general progression for tendon repairs. The pyramid does not include time recommendations on when to advance to the next step up. Advancing is based on practitioners' clinical reasoning. Main causes of flexor tendon injuries include violence-related incidents, motor vehicle accidents, work-related injuries, or self-inflicted injuries. The most commonly injured flexor tendons include the flexor digitorum superficialis, the flexor digitorum profundus, and the flexor pollicis longus. Next, we will review specific therapy protocols. The type of protocol to be used by the practitioner is often prescribed by the referring physician. Advancing through the prescribed protocol should be done at the therapist's clinical discretion. If the therapist has the option to choose what protocol to follow, the reasoning for using immobilization, early passive motion, or early active motion are described in the following sections. All protocols include a form of a dorsal blocking orthosis during the initial period of immobilization. The rationale behind this is to relax the tendons and avoid tension that may lead to a rupture at the repair site. The initial period for all flexor repairs consists of protecting the repair site and promoting healthy wound healing. The first protocol that will be reviewed is the immobilization protocol. With immobilization protocols, there is no active or passive motion of the affected digits for at least 3 weeks. During this time, the patient's hand will be placed in a protected position. Either static or dynamic orthoses may be used. Protective protocols are especially utilized for patients at risk for noncompliance, such as children or adults with cognitive impairments, those living in unfavorable environmental conditions, and patients with injuries that prevent motion, including skin, bone, and joint injuries. Early passive mobilization protocols use passive flexion and passive or active extension of the affected digits after a repair. Motion can begin as early as a few days post-op or at any point in the 3-week post-op timeframe. A dorsal blocking orthosis is used during the first 3 weeks after surgical repair. This orthosis can be static, dynamic, or hinged. This protocol is recommended for those whose type of surgical repair is unknown, patients with significant post-op edema and pain, and those who are unable to attend therapy sessions 2 times per week. In the 3-week post-op timeframe, patients can begin active place-holding exercises. Then shortly after, at week 4, the orthoses can be removed for active range of motion or tendon gliding exercises. At week 6, orthoses can be discontinued if the surgeon is in agreement. Blocking exercises and composite flexion or extension may begin. If flexion contractures are present, serial volar extension orthotics will be worn typically at nighttime. Around weeks 10 to 12, gradually increasing grip strength will be done as needed to return to work. Depending on patient progress, discharge can begin to be considered. Early active mobilization protocols incorporate place-hold flexion and true active flexion of the affected digits. A surgeon's approval is needed before using this protocol. Motion is ideally initiated within the first 5 days postoperatively, although up to day 7 is acceptable. Tendons are at their strongest from day 3 to 5 post-op, and no adhesions have developed yet. This protocol requires a strong surgical repair in compliant patients because it increases the risk for rupture. Progression through early active range of motion protocols may depend on the type of orthotic used. During weeks 1 to 4, passive range of motion exercises of flexion and extension in the PIP and DIP joints, as well as composite flexion exercises, should be completed every waking hour or 4 to 6 times a day. Exercises will be completed within the limits of the orthosis. Around week 4, hinged orthosis use and dynamic traction may be discontinued. Static dorsal blocking orthosis will continue to be worn with use of passive range of motion exercises. Active range of motion tenodesis exercises should be completed hourly without the orthosis. At week 6, the dorsal blocking orthosis can be discontinued. Blocking and passive extension exercises should begin at this time. If composite extension is still lacking, night extension products and orthosis may need to be worn. Around week 8, gradual progressive strengthening should be done as needed to reach work and functional needs. Depending on patient progress, discharge can be completed at this time. This chart shows orthotic usage in the appropriate stage of healing. We will now look at some common orthotics used in flexor tendon repair immobilizations. Dynamic orthoses are used to apply sufficient tension that does not overpower the joint and also allows for the patient to overcome the resistance to move in the opposite direction. Static orthoses are used to immobilize one or multiple joints. A hinged orthosis allows minimal motion in a specific plane of the affected joint. The orthotic mimics the natural motion of the given joint that has been repaired. In some cases, complications may develop after surgery. The most common complications are formations of adhesions, which greatly limit active range of motion. Other complications include tendon rupture, minimal tendon gliding, flexion contractures, excessive scar formation, extreme pain, severe edema, infection, and triggering. As a practitioner, it is important to always be aware of potential complications, catch and treat them as soon as possible. Assessments used with post-operative tendon repair patients include, but are not limited to, grip and pinch strength, disabilities of arm, shoulder, and hand, range of motion, manual muscle tests, patient-rated wrist evaluation, sensory testing, circumferential edema measurements, and a patient-specific functional scale. Choosing appropriate assessments is up to you as a clinician. Assessments are important for making functional goals for clients and tracking their progress throughout therapy. However, when using an assessment, you must ensure that you do not exacerbate any symptoms or cause a re-rupture of the repaired tendon. Physical agent modalities and manual therapy can be essential in the healing process. Transcutaneous electrical nerve stimulation can be utilized early on to treat pain. Scar management techniques are necessary to promote optimal scar formation and prevent skin and tendon adhesions. Scraping can manually assist with breaking up scar tissue. Kinesiotaping also prevents adhesions from forming by changing the tension on the skin surface in an opposing direction as the scar. Edema can also be managed with kinesiotape by altering tension at the surface of the skin to stimulate the edema to move towards a lymphatic drainage point. Manually, edema can be managed by pushing and massaging the swelling back towards that drainage point. Electrotherapy modalities, such as neuromuscular electrical stimulation, provoke stronger muscle contractions. Compliance among patients is crucial to the success of their healing process. Providing patients with adaptations and ways to complete ADLs one-handed will increase patient compliance. Adaptive techniques can be taught for dressing, bathing, eating, and working, and so much more. The first few weeks may require you to be creative to find ways to adapt meaningful occupations for your client. Flexor tendon injuries of the hand can result in a loss of finger or thumb motion, reduced functional hand use, and decreased quality of life. Activities of daily living, such as dressing, bathing, and toileting, may become much more challenging immediately after a surgery. Our hands are essential tools to our functionality and completion of ADLs and IADLs. With the help of occupational therapy, patients can get through these setbacks using adaptive equipment and rehabilitation interventions. Strengthening and work hardening treatments can be used to facilitate earlier return to work, leisure, and sporting activities. Thank you for your time and attention. Good luck, and we hope you found this information valuable to treat flexor tendon repairs in the future.